when these tests are there, I give them the two opportunities we have in the Netherlands available. So for IGHV mutated patients, we have chemoimmunotherapy that is in our box, and so there is no discussion, and they have fairly good progression-free survival and even overall survival. So the issue is more the unmutated patients. And then I tell them, well, we have this experience with chemo and then sequential novel agents, or we can use the novel agents immediately. We know that the progression-free survival is longer. We don't know for sure that the time to next treatment is longer. There are no data about it. Only one poster last ASH, but it is not reliable because it's real world from the States. And there you don't know if the patient stopped their novel agent because there was no reimbursement for because of the healthcare system is completely different. But that showed no difference. So we need to demonstrate that there is at least a difference in time to next treatment when you start with novel agents. And that we have a longer experience with the sequential therapy, starting with chemoimmuno, and that we have a much shorter experience with starting with novel agents. And that the toxicity is similar in incidence, but not on the long term. 25% of the patients stop ibrutinib in the first line. We don't know this with venetoclax because this is time-limited therapy, so that seems not to be the case. Yeah, and I think that's it. Yeah, and of course you tell them about the administration of the treatments. These are sometimes slightly different, only tablets or intravenous administration, but yeah, that's mainly not that part. And what I also tell them is they won't lose their hair. Because that's one of the myths for chemotherapy, that you imagine you lose all your hair, but chemo for CLL, that's not an issue. So, yeah.